Thank you very much. I'm Jessica Ancker. I'm from Weill Cornell Medical College, where I'm with the Center for Healthcare Informatics and Policy. Um, and I've been invited to talk about how all of this relates to shared decision-making, and specifically this concept of explaining risks and uncertainty. So I thought I would begin with a really shocking patient decision that made a lot of headlines earlier this year when Angelina Jolie publicly disclosed that she had tested positive for mutation at BRCA1 or 2 and chose a prophylactic bilateral mastectomy to handle this. It certainly got a lot of attention because of who she was and because of the sort of radical nature of what she chose to do about it. I thought I would take a moment and actually look at the editorial she published to talk about what the processes were. So she talks about her own family history of breast cancer, which was very high. She talks about wanting more information and seeking out the BRCA test. This is when it was protected by patent earlier this year. Um, and then she tested positive. She was given a lifetime risk of disease that was in the neighborhood of 80%, so extremely high. She explored her options. She talks about their advantages and disadvantages, primarily in light of the risk of disease, of preventing that disease that she found very frightening, but also in terms of other things that she found important, such as appearance. And what's very interesting about this is that it really conforms with our societal expectations for shared decision-making and informed decision-making. This is a situation in which the patient gathered relevant information, understands the risks and the options, and then engaged in the decision-making process to the extent that she felt comfortable. This considers the possibility that some patients would rather have the doctor take a more lead role in that, and some patients would rather take a more engaged role themselves, and that there's quite a lot of variability. But according to our societal expectations, this is what we mean really by shared decision-making. You can see that this is a tough sell for a low numerate population. If we're expecting that patients really need to understand the risks as part of this shared decision-making. So a quick moment to talk about definitions. Mostly what we're talking about in the medical realm here is epidemiological risk, which is the probability of developing that disease, the number of people who get it over some time period, over the total number at risk. It is relevant to point out that many people are also familiar with more of an economic form of risk, which is this probability times utility concept. To make that more concrete, I will say most people in this room would agree that a 1% risk of developing breast cancer is worse than a 1% risk of developing a cold because of the higher, I suppose I should say, disutility that we place on breast cancer rather than cold, even though the epidemiological risks are equivalent. And so it's worth noting that right there, that's the potential for a miscommunication with patients if they are thinking about this more in a sort of the economic type of risk as opposed to the epidemiological type of risk. And then, we can also talk about uncertainty, which are situations which it's reasonable to assume that there is some risk, but we don't really know what the magnitude is. A classic example is a newly approved drug. We just don't know what the long-term safety profile might be. If Angelina Jolie had tested positive for a variant of unknown significance, that would have meant that there was some abnormality in that gene, but it's so rare that it's not clear whether it carries any risk or not, what that might mean. Another example would be confidence intervals, where we know there's a range of plausible estimates for what the risk might be. I'm really going to focus on the first of these, epidemiological risk, because in the context of shared decision-making, what we expect is that the healthcare professional or professional community communicates the epidemiological risks to the patient, and then the patient is supposed to then talk about their personal utilities, the personal values they place on things, and that this is a sort of an iterative discussion. We talked earlier, a couple of people mentioned the difference between persuasive communication and unbiased informative communication. A lot of the risk communication literature comes out of the public health realm, in which persuasive communication is the norm and is considered ethically appropriate. We don't really care if you understand what your personal risk of developing lung cancer is. What we want you to do is quit smoking. As opposed to in shared decision-making, it's a narrower realm. What we really want people to do is have a better sense of what those risks are. And as a result, a lot of the public health risk communication literature focuses on non-quantitative ways of expressing risk, framing or fear appeals, as opposed to a quantitative risk communication, whereas in shared decision-making, there's a very strong emphasis on making sure patients understand what their risk of disease, what the quantitative risk is. Therefore, low numeracy is a really big hurdle for shared decision-making. A number of us have talked about numeracy, so I don't need to talk about it here, but I will just say that it's not just, as we all agree, it's not just computational abilities, but it's a whole constellation of other issues involved. And it's pretty clear there's fairly good evidence that people with lower numeracy skills are more reluctant to engage in shared decision-making, and this may be, in fact, one of the reasons why. I would like to make explicit a point that many of the different speakers have talked about, which is that competent use of quantitative information is not solely dependent on the patient's skills. We tend to talk about numeracy as a quality or a skill or an ability that the patient brings to the table. But in reality, what we know, the patient brings skills as well as previous knowledge and perceptions. But the person providing the information brings a lot of skills to the table as well. They may be good communicators or poor communicators, so that the competent use of that quantitative information really comes out of this interaction, not just solely the patient's skills. And an area of particular interest to me, and I think of many people in this room, is that frequently that discussion is supported by or informed by some document or website or artifact that contains information in it. Those things may be designed well, they may be designed poorly. They may be designed in a way that might help compensate for low numeracy or increase the numeracy burden on the patient. So this is an explicit description of something I think that we all agree on, and it was a proposal that we put forth in a paper in 2007 about what does numeracy really mean, and that quantitative understanding arises out of all three of these things. And I would just like to add the obvious, which is that the patient is making sense of this not alone, but in context of a social network, in context of a physical environment that may carry risks or no risks, and in context of an information environment that contains all sorts of news stories and television and radio and online sources as well. So let's go back here for a second. Let's talk about what the information provider should be thinking about and what the document or website or information artifact should be designed with in mind. What are our options for explaining risks? Well, broadly speaking, we've got words, we've got numbers, and we've got pictures. So let me talk very briefly about each of these. And I'll just quickly say, Bernard, you raised a question earlier about words, and I'm not really going to be making a distinction here between text, verbal, and oral presentation, because I agree that there hasn't been a lot of really interesting, high-quality work about the oral presentation of this information. It would be great to do, though. So let's talk about words. I think this has obvious advantages and disadvantages. We know that words are familiar to patients. They certainly convey that affective impact that patients say they want. They want to know what this means. And words are the way to do that. This is a big risk. This is a small risk. This is not common. This is something you should be worried about. This is something you shouldn't be worried about. And there's fairly good evidence that people at the lower levels of numeracy say that they prefer verbal descriptions of risks and that they trust information more when it comes packaged in that format. The disadvantages, I think, are also very clear. It's not very specific. There is fairly good evidence, and Ellen Peters raised this earlier, that people tend to overestimate what a particular risk word means. If I say your risk of something is rare, and then I ask you to tell me what you think that means, people will come up with something in the realm of 10 or 20%, when in fact I may have meant 0.5% or lower. As a result of these, it's really hard to use words alone for very good comparisons. Is a very small risk better or worse than a rare risk? I mean, who knows, right? So we can move on to say let's provide the numbers. And there's a strong preference in shared decision-making. And if you look at the, for example, the International Patient Decision Aid consensus, we should be providing patients with these numbers. So one option is percentages. These are generally fairly familiar. They are independent of sample size. 2% of a small group is the same thing as 2% of a large group. But we encountered a lot of the problems with them earlier today. People don't know how to manipulate them. They don't necessarily, people at particularly lower numeracy levels don't necessarily know how to calculate them. And there's pretty good qualitative evidence that people perceive them as relatively abstract. It may not feel like it really applies to me. The difficulty in manipulation is a long-standing problem. If I start out at this risk level and then this intervention reduces it by 30%, where did I end up? We've known for a long time that many patients can't really perform this reliably. There's been a push also for frequencies instead of percentages to say 23 in 100. And this is the standard of communication for things like genetic risk counseling. They typically do these rates rather than frequencies rather than percentages. Very good evidence that people perceive this as vivid and personal. I keep citing the work of other people in the room here, so I hope that everyone recognizes that I'm relying on the consensus of a lot of really great people here. And that people have a fairly easy time applying this sort of information to themselves. There are also a lot of disadvantages that it's worth pointing out. It may very well inflate the sense of the perceived risk, again, among the less numerate, compared to percentages. There are two other problems with these, which I'm going to call denominator neglect is the standard term, and then the second term that I'm kind of coining here is denominator confusion. So denominator neglect is a long-standing, well-known phenomenon. For the less numerate, people may not recognize that these two risks are equivalent, and that they are likely to get attracted to the numerator and say, well, 230 is bigger than 23, so therefore that bottom risk is actually larger than the top risk. The denominator confusion issue is what happens when we present two different risks to people with different denominators. Again, fairly good evidence that people in lower educational brackets are likely to get their attention focused, in fact, on the denominator and not recognize that 1 in 20,000 is, in fact, quite a bit smaller than 1 in 5,000. Or more subtly, perhaps, if you want to know how much more rare is that they are not quite sure how to make that judgment as well. Sorry, there's as a result of this, there's been also promotion of the idea that we should always be presenting information with the same set of denominators, so that the bottom one there would turn out to be 4 in 20,000 versus 1 in 20,000, to allow people to make that comparison cognitively more easily. The third option that we've got is various sorts of graphics. I'm going to talk very briefly about some of my work in this area, but I also included a review article that we wrote in your packet, which goes into somewhat more detail. One reason that people like graphics is not only are they visually interesting and they attract our attention, but they exploit not only learned skills, but also automated visual perception, things that we don't have to learn. For example, if I show you these two bars and I ask you which one's larger, that is an automated task. There's not really much learning, if any learning involved there. As long as those two bars are on the same x-axis or the same horizon, we can automatically tell which one's larger. And in fact, if we ask people to judge how much larger is the one on the left, that's fairly automated as well. Numeracy skills have something to do with how well we verbalize that, but we can still tell that quite easily at a more or less automatic level. But the learned part of that is, what is this x-axis? What is this y-axis? How does this information apply to me? So it's certainly, this is not independent of learned skills at all. In our review of the graphical literature, we drew some principles. So let me talk about a couple of these principles that apply to all different types of graphics before we talk about specific examples. Whether the part-to-whole relationship is visible is critical to how people are judging these. So here's an example of a graphic in which the part-to-whole relationship is not visible. I can see that the risk was 10%. It is now 6, 7, looks like 7% here. But I do not have the context of the entire 100%. So if I extend the y-axis up there, I can see how this relates to the part-to-whole. So I think it's fairly obvious now that I've said this, that the graphic on the left inflates the apparent difference, and the graphic on the right somewhat minimizes it, or at least places in context. Here's an example from icon graphics as well. Your risk is a certain number of icons. The average risk is another number of icons. But by placing it in context of a larger number, I can show the part-to-whole relationship. I'd like to just say that this is very relevant to the consumer union study presented earlier today, in which people's judgment about how important that the deductible cost was changed radically once they recognized that the entire cost of the procedure was $100,000 and that their deductible was $2,000. And now the difference between a plan that had $2,000 deductible versus $1,000 deductible was much smaller once you recognize that the part-to-whole relationship was that there was $100,000 in background. So I just thought I'd make that link to your presentation earlier. The part-to-whole relationship has to be easily visible before people can do this on an automated level. Anyone want to guess what this what this percentage is? So once I line them all up, I think most people can see very easily that this is probably somewhere between a quarter and a third. Interestingly, however, some very good qualitative research done by others, as well as some done by us, suggests that that left-hand arrangement does a better job at expressing this sort of qualitative idea that anybody is at risk, that risk is haphazard and random, and that anybody might be affected, whereas the one on the right makes it seem somewhat more controllable and tidy, and perhaps I'm up there in the yellow and I don't need to worry about the blue so much. So there are some different dimensions of communication effectiveness that we might be thinking about here. Judgment's most accurate when only one dimension varies at a time, and here's an example of what I mean. Here's the two bars that change in height, and here's the two icon graphics where they're changing in area, height and width at the same time. People are quite poor. If I ask you to judge how much different those two are, we don't do a very good job, and our perception skills go down even further with circles. So when we're talking about pie charts themselves are a good way of demonstrating that part-to-whole relationship. But if we're talking about pie charts of different sizes, I've seen people try to do that where we've got one little pie and one big pie, and they're varying in their part-to-whole. That's sort of a recipe for confusion. We're not exploiting our inbuilt cognitive visual perception skills. So let me take a moment to talk about 3 different types of graphics that have been pretty well studied. One of them is this icon graphic, lots of little people, either in smiley faces or stick figures or bathroom icons. These are pretty widely used now. There's a very clear visual analogy with the risk information. It's a whole bunch of people, and some of them get the disease. It does exploit these abilities to visually process sizes at an automated level, so probably relying somewhat less on learned information, well accepted by people with low numeracy, and that part-to-whole principle definitely applies here. Bar charts are also fairly well accepted. Many people find them pretty familiar. We do see some evidence that patients think of them a little bit more abstractly. Again, it's a little less clear how it might apply to me. There was an interesting study suggesting that when you ask patients, they prefer graphics with fewer visual elements in them because it looks simpler. And so they tended to say that this information in a bar graph looked easier to understand just because there was less moving parts in it, which I can see the rationale there. The part-to-whole principle very strongly applies to this. And just quick mention of another graphic that we don't see so much in health risk communication. I've seen it much more used in environmental risk communication, which is risk ladders or risk scales. The advantages of these is that really only one dimension is varying at a time. You can compare positions along that line very easily. It's a fairly familiar visual analogy with a thermometer or a location, something like that. It does permit the addition of comparative information or some sort of action threshold. This was mentioned earlier today. Once your risk gets to this point, maybe some action is important, or once your risk gets to this point, you have exceeded the average risk for people of your age or category. The one on the bottom was developed by Steve Woloshin and Lisa Schwartz at Dartmouth, and they got fairly good results in terms of eliciting risk information. And what I thought was interesting is that they used this visual analogy of a magnifying glass down at the bottom end so that you could really try to zero in on those very rare risks way down at the bottom end of the spectrum. Just a quick note to say that conveying rare risks is a huge problem, and nobody's solved this, so that would be a really great solution to have. How do you express very, very rare risks and help people compare them in a meaningful way? Given that these graphics have different advantages and disadvantages, what do patients want? Unfortunately, when you ask patients what they want, you get some odd answers. You can see that some of this will improve satisfaction with the information, but it doesn't actually change their decisions. So it's not clear really what's going on here, whether it's helping them or not. As I mentioned earlier, patients sometimes prefer the more visually simple ones, even if they have less information in them. Patients do not necessarily answer comprehension questions better with the graphic type that they prefer. And I thought I would just mention that doctors don't either. This is a really great study showing that doctors hated those icon graphics, but did a very good job of identifying risks with them. So there's been now some discussion here about multiple representations of the same information. Would it be better for patients if we did more innovative types of layered information? And I'll just say a caution is that, as some people in this room have demonstrated, it's possible that what you will in fact get is cognitive overload instead of better information, better understanding. So I will just quickly show an example from my own work in which we were looking at an innovative sort of game-like interaction in which instead of merely telling people what their risk was, I also let them sort of explore, keep clicking until you find some of those blue people that have the disease, and click around until you find them, and then you will be able to see the entire pattern. Interestingly, what we got was the more people clicked, the more anxious they felt, which was sort of exactly the opposite of what we had hypothesized. We did find that this was very attractive and people liked it a lot. However, I want to point out that this was followed very closely by a paper by Brian Sickman Fisher over here in the corner with another sort of interactive graphic in which people were invited to graph their own risks. And he found that the dropout rate was so much higher, and that in addition, the interaction did not, in fact, help people identify the better of the two options. And so he titled that paper "Cool but Counterproductive," which I think is another pitch for the fact that these innovations really need to be studied before they get deployed and before we assume that they're going to solve these problems. The final issue and challenge that I want to mention is we've talked a lot about the Affordable Care Act here, the Affordable Care Act of 2010. I want to draw your attention to another act, the HITECH Act of 2009, which is also massively changing the face of medicine, but may not be as obvious to people who are not themselves doctors. This is the EHR, the Electronic Health Record Incentive Program, in which doctors and hospitals can receive financial incentives for computerizing their medical records. Not only that, if they don't do it, they're going to start to receive penalties. So over the last 5 years, we've seen a massive increase in the number of healthcare institutions who use electronic health records. It's either doubled or tripled, depending on which survey you buy. What may not be well known is that in the later stages of this program, there's not just a suggestion, but a mandate that in order for these doctors and hospitals to collect their financial incentives, they must make electronic medical data directly available to patients. So I put this out there as is a massive, a nationwide experiment in health communication. We have no idea what this is going to do. Patients can log on. This is the example here at my institution at Weill Cornell. Patients log on there. This is an account that I set up, but it doesn't have any data in it, so I'm not actually due for my mammogram, even though it says it. Patients can log on there and they see their ICD-9 codes. They see their diagnoses that have been put in the record. They see their medication list. And this has, depending on which product's out there, there's minimal massaging of this to make it comprehensible to patients. They can see their laboratory values, their glucose levels, their CBC if they want that. Many times they can see their operative report. In ours, they can see their radiology reports in the original language that the radiologist wrote. So what we're seeing is, at least anecdotally, an increase in patient concern and anxiety because they are seeing what the doctors are actually writing about them, and they do not understand what this means. So I will conclude with a sort of a list of issues and challenges of areas where I would love to see additional research. I myself am hoping to do some of this, and I would really love to see the Institute of Medicine take on some of these as areas for further discussion. One of these is these novel communication modalities that are available online, things like games and things like interactions. We don't know really whether they are beneficial or not. And then this massive experiment in releasing medical records directly to patients. How do they understand all of that information, but particularly the quantitative information? How does this affect shared decision-making? How does this affect risk perceptions? What sorts of interventions can be done on the electronic interface that makes it more useful for patients, more productive for their decision-making? So with that, I will conclude and say if I do also have a bibliography that I produced for this slide presentation. I would be very happy to share it with anybody who wants to contact me. Thank you very much.